Showtime. My name is Josh Dufresne. I'm the CEO of North Star Health. I've got an interesting background. Marvin may have shared with you some of the background that I've had and kind of what I've been through. Maybe first I should tell you what led me to healthcare. I didn't start out that way. I didn't start out looking at healthcare at all whatsoever. I'm an extrovert by nature, so I like people. I like relationships. That's something that I've always been drawn to. And I started out, believe it or not, in data telecommunications. So I was a IT guy. And one thing that you already know is everything is systems, right? And so if you know a system, you can pretty much apply to other systems and you start to understand functionality. I was recruited by the hospital here in Springfield, Vermont, back in 2006. So I'm on my 20th year with the system. And I started as the director of patient financial services, and I had absolutely no experience whatsoever in hospital billing. I don't even know why I said, sure, I'll take that job. But I have absolutely no regrets on taking that job. And it really came from a place where I was making a connection. This is old school, but we were using T1s. This is before fiber was a thing. And it was PACS radiology images back and forth from our Ludlow site to Springfield Hospital site for the radiologist team to review images. And I didn't think we could pull it off. We pulled it off. Shortly after that, I got a recruiting letter from the Springfield Hospital. And what I did notice is the group was fun to be around, which was really cool to experience. They definitely took what they did seriously, but they didn't take themselves too seriously, and I really enjoyed that too. Um, it was an environment where you could fail something. You could make a mistake and you could learn from it and you could rebuild. And I thought that was just a really nice environment to be in, because I was so used to perfection every single time, all of the time, which is what I strive for anyways. But that can also be a little debilitating if that's the cone that you live in, with your experiment with different things. After being chased a bit by Springfield Hospital, I took the job. And as I said, I didn't know anything about patient financial services. I was in that role for a few years, and we really cleaned up a lot of the receivables that the hospital had in the correct way. We implemented a new financial aid program, prompt pay discounts, really helping a community of underserved population that really can't afford to pay their bills sometimes, just because the cost of healthcare and reimbursement from insurance is just nil. So what I really learned is how healthcare doesn't get paid for. And that blew my mind because I was so used to, and I use this analogy all the time, but I was so used to if you get an invoice, you pay the invoice. That's certainly how it's been in my life. If I bring in my truck for some kind of service that I can't do on my own, then I get a bill for $300. I pay the $300. The analogy I always use is the grocery store. And we have a grocery store here in Springfield, Vermont called Shaw's. And it's the most expensive grocery store, I feel like, in at least 100 miles from where we live. And there's a population that just simply can't afford it. But what I use and what I pick on them all the time, I'm surprised they haven't called me yet. But there's no other industry really like healthcare where you can actually negotiate the price that you're going to pay, and that's what we do with insurance companies all the time. Medicare, Medicaid are hospitals' most difficult payers. They're not going to pay the hospital the most as far as a percentage, right? And that cost shift falls on commercial payers. So that's your Blue Cross, your MVP, Cigna payers. So I always think about going to the grocery store and having $100 bill of whatever I purchased at the grocery store and saying, I know it's $100, but I'm contracted with this company, and so I'm only going to give you $50, and you have to get the other $50 or write it off, as a cost of doing business with the contract. And as soon as I learned that that's how hospitals got paid, it made sense that prices were higher because they're not collecting 100%. The hard part was you're collecting 100% from people that didn't have insurance. And that drove me crazy because there's nobody fighting for them with the contract, right? So they are on a payment plan for the rest of their lives, usually without interest when you're working with a not-for-profit hospital. But we straightened a lot of that out, gave people better discounts, changed our financial aid policy, and that really helped with a lot of people that really needed it. And then I moved into primary care management and working with primary care. And what I noticed in primary care is I really like the human side of it a lot more, than the human side of it on the billing piece of it, because you have folks coming in and nobody is coming into the healthcare setting well, some do, maybe looking really forward to it. But a lot of people have a challenge that they're trying to work out, or they have a problem that they need help with. So it's an emotional environment, right? And we really experience that in all levels of the organization. And how can we be compassionate, and how can we help them with wellness, and getting to a place that they need to be? I'm certainly not a big pharma fan. I do not like pharmacy. If we can make changes with people's healthcare through lifestyle medicine, or is anybody familiar with lifestyle medicine? Yeah. Okay. So really that stress reduction. And when I talk about it, stress reduction, people are like, yeah, absolutely. I could go with that. Better sleep. Everybody's on board with better sleep, right? Nutrition, you might start to lose a few folks because you start to talk about some healthier options, and people might be, but I like this option and it's not maybe most healthy for me, or different habits that people have. And so you lose a couple people there. And then when you get into exercise, you might lose a few other folks. But it doesn't have to be 100% all of the time, and I don't think it can be. And we've been working on lifestyle medicine with both medical staff from a physician level, but also behavioral health staff from a psychology level. And that's been just phenomenal. We've seen people's lives change, and it's just baby steps. Get up off the couch and walk around the couch a couple times, and you don't have to go out and run 10 miles in one setting because you're never going to do it again. It's those kind of things and those kind of conversations that you have with folks that I don't think things like NCQA medical home, I don't think they've caught up to that yet. Obviously, healthcare is an industry. It's an industry that's under attack right now. And I think probably a big portion of waste that happens in the medical industry is true. I also think that it's not necessarily happening at the caregiver level. I think it's happening in the insurance level. I think it's happening in the big pharma level, but certainly not in the direct care. And I think the philosophy that we're seeing across the country that I struggle with is really not putting a lot of benefit or a lot of focus on the need for preventative care, for primary care. And you see a lot of hospitals that are reimbursed with primary care as little as possible, and you're making all of your money in the OR. And so where's the incentive to keep people out of the OR? It's not really there. Where's the incentive to hold back on doing knees and hips? Because knees and hips are going to pay for all of those things that they don't get paid well for in healthcare, like primary care. But primary care isn't necessary, at least from a hospital perspective, because they need those referrals coming into the organization. For me, I have a different outlook on it. Primary care is a necessity because we're keeping people healthy, and we want to keep people out of the hospital. And so that was such an interesting experience for me. As I started with Springfield Hospital in 2006, as I said, we're trying to build a machine that creates revenue that can pay for increasing costs all of the time. And so what services are paying for themselves, what aren't paying for themselves? In 2019, Springfield Hospital hit a wall, and we went through bankruptcy. And when we went through Chapter 11 bankruptcy, I was in operations. I was the chief operating officer at the time of the FQHC, Federally Qualified Health Center. And I was over all the surgical practices, inpatient hospitalist practice. What I wasn't over is the emergency department and radiology. I think those were the only two I wasn't over. So it was like a wildfire coming through the campus. Certainly lost a lot of people. The right people stayed, and the people that were really dedicated to the organization to try to carry it through to the next level. And the idea was once we had the hospital in Chapter 11 and the FQHC in Chapter 11, because there were two different companies, and we were one of the only companies, if you will, in America that had primary care elevated as an FQHC over a critical access hospital. Gifford Medical Center in Randolph, Vermont is like that now too. And there's a mini Hamilton down in West Virginia, which is very similar to that model. But the whole philosophy was to keep people out of a hospital. And that kind of sounds weird because you want a hospital to survive, but if the hospital has less volume, how do you do that, right? So it's really thinking about keeping people healthier, which is what healthcare should be. Otherwise, we're practicing sick care, and really being able to take care of the population that you look at, measuring outcomes, measuring the quality scores. Are we making an impact, or are we not? And if we're not, why are we doing it? Could there be somebody else that could maybe do it better than us? I think I'm really, I don't want to just keep on talking too. So I want to ask, if there's questions too. So feel free to raise hands if y'all do have questions about things that specifically that I'm saying. But right now, Springfield Hospital is separate from our federally qualified health center, North Star Health. And North Star Health was a company called Springfield Medical Care Systems, and that was the overarching company above Springfield Hospital. So if you want to go look at 990s and you want to see what it looks like to lose a lot of money, you can look at our 990s, and I can tell you some of the things that we've been doing to try to battle that. But we certainly are, as we moved from a combined service with the Springfield Hospital, and we still work with Springfield Hospital very collegially and collaboratively, but now we can focus on just us as an independent FQHC, keeping people healthy. And the primary care is a big one. We also do acute walk-in. We do vision care, so we're doing eyeglasses downstairs and eye exams. We do dental care, and we do a huge amount of behavioral health. And what I'm trying to do is I'm trying to integrate that all together. And FQHCs are paid much better than a hospital. As I said earlier, those hospital payers that are the weakest, the Medicare and Medicaid, those governmental payers, are my best in the FQHC. So I get paid an encounter rate, which is every visit gets paid the same amount, whether it's 30 minutes or 2 hours, we're getting paid the same amount by both Medicare and Medicaid. We also get paid our encounter rate by Advantage plans. So we have a lot of patients that are migrating off of Medicare and getting onto like a Medicare Advantage plan. And so those help us. They don't help the hospitals. If you can imagine, if somebody had Blue Cross and they move to a Medicare Advantage plan, they're not going to be getting the Blue Cross benefit of a higher payment. And we're at a unique time where the cost shift has happened so long. Blue Cross has put up their hand of Vermont and says, we can't do this anymore either. And they're on the brink of bankruptcy as well. And so I've been brought to a lot of meetings with the Green Mountain Care Board. If you're not familiar with those folks, I can definitely elaborate more on there, as well as AHS, so Agency of Human Services. And then the DEVA, we call them Department of Vermont Health Access. And so we all get in one room and we talk about what do we have to do to revolutionize healthcare delivery in Vermont? Because right now we have a healthcare delivery system that the state cannot afford, and Blue Cross is getting ready to go bankrupt, or at least they need a major bailout by the state of Vermont, and potentially hospitals helping that happen. And insurance premiums are going up so high that businesses in Vermont can't afford them anymore. And so we're at a very unique time, just on a state level, not even getting into the big, beautiful bill and some changes that potentially could come with the loss of Medicaid covered lives. And it's been a difficult piece. It's been a difficult organization to run. When we were independent, last year we lost $3 million. That's not something that's about $3 million. It's not something you can continue to sustain, obviously. So how do you do that? And right now it's really fee for service, a lot of the way that we get paid. So it's volume. And that is the absolutely worst way to get paid when you're in healthcare, because what I have to do is I have to say to my providers that currently work with me is I'd like to get to at least 16 patients per day in my primary care group, 8 a day in my behavioral health group. And, that's not the best way to provide care. That's you're running a breeding facility for AKC registered Labradors, right? It's the puppy mill. And that is certainly not what I would want to go to buy a puppy either. So we want to have people take time with their patients. We want people to have that life balance and have a time away with family to come back and be their best. And we certainly see that being asked for by the new graduates coming into our organization. Certainly never saw that from what I call legacy clinicians that have worked for our organization for years, like people like Marvin's age, that are their whole life has been dedicated to medicine, and it doesn't matter what time of day they're available. We're not seeing that anymore. We're seeing a lot of vacations taken. We're seeing probably an increase in our FTEs taking care of the same number of population. And so the cost is up. So reimbursement needs to change to keep up with the cost. And it's not really done that very well. The state of Vermont's made some recent changes to keep up with reimbursement. So has the state of New Hampshire with both of their Medicaid programs. Medicare has increased, but commercials haven't really moved the needle much. They still pay us on a fee schedule. And then we also haven't had an increase from the United States government on our 330 grant, and it's not looking good for that either. So how do we make it work into the future is a big question mark. And how do I position people around the table? And that's what I'm doing a lot of now, to collaborate around services and potentially shared services, and get away from this territorial competition that we find in a lot of the healthcare delivery systems. So I'll pause there. I just said a whole bunch of stuff. And some of it may be interesting, some of it not. So I'm happy to answer questions or dive into something deeper if you'd like.
Oh, thank you so much. You touched a little bit on what I was going to ask you, so like some of the problems that rural primary care centers face,
Sure.
despite having federal funding. But I was wondering if you could talk a little bit more in detail about what it took for Springfield to recover from bankruptcy and kind of
Hmm.
that transition period.
Sure. I think so. I mentioned a little bit of the perfectionism piece that I have that's just bred into my body, and I don't know where it came from, but it's there. And if you're a perfectionist and you understand that you have to declare bankruptcy and take a company through bankruptcy, that's a hard one, just emotionally and mentally to carry around, because you feel like you're wearing the scarlet letter everywhere you go, or at least I did. And it's like a big red B. And it's on your chest, right? And so it was something that we had a lot of news coverage on. So a lot of the local news coverage would come and stand in our parking lot with their cameras and talk about the bankruptcy of the hospital in the background. And you'd have a lot of patients that would hear that. And a lot of those patients would say, ooh, if they've gone bankrupt, that means their care's no good. I better not go there. And the reality of it is that's untrue. We protected all of our providers and our staff from the bankruptcy to the best of our ability. We would give updates, and so they knew what was going on. They knew where things were, but it was a financial restructure. It had nothing to do with the actual care delivery. And so being able to share that message was key throughout the bankruptcy. Also, there's days that I'm a very transparent leader. And so there's days that I was sharing with my staff that we had hours of cash on hand. And for those of you that know what that means is if you just stopped billing or if you didn't receive any of your reimbursement, you would be able to survive however many days you have on hand. It's a pretty good benchmark that the healthcare system uses. And you want to have, 150 days of cash on hand, meaning if you didn't receive any payments from insurance companies, you could last 150 days, make payroll, those sorts of things. Well, when you have hours of cash on hand, that's a lot harder to make payroll, right? All of a sudden, there's like an internet outage and you're not getting your reimbursement on ACHs from insurance company or something, and you don't have any savings to dip into. So that was a stressful time. The other piece is recruiting. Who wants to come take a job at a bankrupt organization or one that just went through bankruptcy? And so it was really a story that we had to tell. We had to educate the population. We had to educate everybody around us of why we did what we did, which was to really relieve the organization of debt that got too heavily leveraged into a debt position, counting on reimbursement changes and counting on shared savings from ACOs and things like that that didn't happen. And so that was an overextension. It's just like if we did this in our personal lives and we spent all of our savings and then all of a sudden something like our car breaks, and what do, right? Well, banks don't want to loan you any money if you don't have any income and ways to predict things either. And so it was very difficult during that process. At the same time, if people are familiar with the Payroll Protection Plan, PPP, you couldn't apply for that and get it if you were in bankruptcy. And that was happening during COVID. So we went through bankruptcy at the same time as COVID. Um, so that was that was a special kind of difficulty, let me tell you. At the same, because you're losing some staff. There was not enough staff. There still isn't. In the nation, there's not enough staff. But I think those were the biggest hardships that we faced, was the volume side of it. Uh, Inability to create billable encounters and cash was tough because people were told to stay home, not use the medical offices unless it was a major respiratory issue, or they thought they had COVID and they needed testing. So that was tough. So controlling the messaging and being as transparent as possible was essential to retain the staff that we needed. And then all of a sudden, it was very odd when we came out of bankruptcy. We needed to really be independent and recruit people to our organization. I'd have people come in and for job interviews, and I would do usually a phone screening first. And this is mostly medical staff that I would be interviewing. And I would tell them, I said, here's where things are in our cash and our portfolio. And then they'd be like, okay, well, that sounds like every other place I'm interviewing. And it was interesting. I mean, it was just, for me, it was all of a sudden seeing outside of the bubble that all of these not-for-profit small healthcares across this New England that I was speaking to were struggling just as bad as we were. But we may have been the canary in the coal mine of what's going to happen. And I think over the next at least in Vermont, over the next 5 years, you're going to see some major shifts in the way healthcare is delivered. And I think we'll have less hospitals than we have today. And some of those hospitals may be transitioned to being collaborated with another hospital. And they might be like an outpatient site potentially, or an ED, or a rural emergency medicine hospital. We're starting to hear those words. So I think it was a precursor of what's to come, but that's really some of the biggest challenges that we had during bankruptcy. I hope that helps.
Does anyone else have any questions? Yeah, Mackenzie.
I was wondering, you mentioned that you've kind of introduced more like financial aid programs and stuff to try and assist patients in getting the care they need. And, with the fact that the hospital's struggling financially, has there been anybody that's tried to kind of encourage you to cut some of those programs to make it to kind of to lose less money? Is anybody kind of pushing for that at all?
Um, that's actually, it's an interesting question. Over the years, that's fluctuated a bit. We have had a 300% federal poverty guideline sliding fee discount schedule. And so the federal poverty guidelines are updated, and we just are 300% of that for the hospital side of it. And we were, at the time when we became an FQHC in 2009, we wanted to retain that 300% of federal poverty guidelines. Oddly enough, the feds have a rule, or HRSA does, that governs the FQHC, that you cannot exceed 200% of federal poverty guidelines. And so we actually had to reduce it for FQHC. Now, when you're one system, that's pretty much a pain in the butt, isn't it? So if now I got 300% over here at the hospital, but at the other, outpatient side, it's not as much. So that was a pain in the butt. So we couldn't go back up on that. And then the states made some changes, which I'm not part of being in an FQHC, but a hospital just had to increase their financial aid benefits. And so they've actually been asked to do more. And I think part of that is to really combat the population migration out of Vermont because they can't afford healthcare. And you're seeing the baby boomer population require more healthcare, and there's less of us people to take care of those folks. And so I think they're trying to do everything they can to remove those barriers. What they are actually doing is creating a greater hardship on the hospitals right now because their inability to collect is already so great, at least in the very rural setting that I'm at. So no, nobody's saying, cut back on that. If anything, what we're hearing is we need to reduce our costs. And that's a common trend that we're hearing in our healthcare delivery model. And I'll give you an example of cost reduction. So this is a fun example. So I almost probably got fired when I did this. So I was I think I was the chief operating guy at Springfield Hospital and Springfield Medical Care Systems, and we were building out in 2013 the building I'm sitting in now, which is an old factory building that's been converted to primary care. And we had this walk-in room, this walk-in hallway that was for walk-in care. So it was like urgent care, but we call it walk-in care. And it's kind of like it's like a same-day primary care solution. So it's not exactly urgent care. And so there was a big room next to it that I wanted to put an x-ray machine. And at the time, the hospital was provider-based. And provider-based allows it to be billed as an outpatient department of a hospital in a rural setting, not on the campus of the hospital. And that's what this was designed to be. Well, over the years, they lost that designation due to some poor decision making, I think. And the outpatient setting for an FQHC gets reimbursed much less for a radiology image, than a hospital. It's paid on a completely different fee schedule. And so what might be something of, $100 reimbursement for us might be $1,000 reimbursement for a hospital. And I'm just making up those numbers. But doesn't that make a lot more sense for somebody that comes in a non-emergent state that needs an x-ray? They were out playing soccer and they rolled their ankle and they need to have an x-ray. Well, if it costs less for me to do it, wouldn't it be cool if you did it here? Because you're going to save the insurance company, you're going to save yourself, copay, those kind of things, deductibles, whatever the out-of-pocket expenses, even more. Same technology, same great x-ray service, same great tech, and it just is reimbursed less. In fact, it's reimbursed so much less that I can't pay for the cost of the x-ray tech, and I can't pay for new equipment. So those are some things that potentially could be looked at of a way to change the way that we do things. And it was funny, the why I almost lost my job on that is, and I knew it was the right thing to do. And we had a CEO at the time who was a role model of mine and really a leader through compassion. It was just a great guy named Glenn Cordner. And I asked him, I said, we have an x-ray machine that's in storage offsite. And I was thinking about just bringing it down and putting it in the off of walk-in. And, since it's stored for here, and then we'll move it down here, we'll just store it in the room in case we ever want to turn it on and everything. And the room had already been designed and outfitted, lead lined and everything. It was made for x-ray. And so he was like, yeah, I guess, I guess that makes sense. But we make so much more money in the hospital with x-ray, and they're less than a mile away. It doesn't really make sense to have x-ray at your location. And I'm like, yeah, I get where that is going. But the reimbursement side of it, I'm thinking, it's easier. I see these moms and dads carrying babies in there. Wouldn't it be nice if they could just get it done there rather than say, yep, you got to go up to the hospital and get a chest x-ray to rule out pneumonia. Just do one-stop shop. So I told our head of engineering, I said, go ahead and move that x-ray machine and just put it in the room and get that just set up. And he says, okay, that sounds good. Well, what he heard was, I want you to call the physicist and I want you to do a test, make sure you get everything set up, fully build that out and get it ready to turn on because we're going to go live. And I didn't say that. I just said, put it in there, right? Well, put it in there meant get it done. And so he did it. And it was a meeting that came up and the CEO was in there and we're talking, and the engineer comes in, he says, we're all set. The x-ray is all set. You can probably go live with it tomorrow. And my CEO was like, I thought we were just storing it in there. And I was like, I thought we were too. And it was just like, whoops. And we ended up using it and we ended up providing x-ray services, which was the right thing to do for the community. And the CEO that he was my supervisor boss, he knew it was the right thing to do too. We don't do x-ray anymore. I actually had to cut that entire service from our organization because we were losing so much money on it. And because we had an inability also to pay x-ray techs a wage that was competitive because there was a shortage and they're all going to hospitals. Same could be said with nurses, same could be said with doctors, same could be said with my hygienists in my dental office. It's really scarce to find resources in our area, and which was tied to the bankruptcy thing too. So hopefully that's a good example of some of these cost pieces that we play with every day. It seems laboratory services is another good example. These ancillary services, hospitals lose some money on lab as well, unless they have major volumes. And so partnering with national laboratories makes a lot of sense, but not a lot of them want to do that. Zachary.
I was interested, I'm very interested in primary care and, like you said, trying to avoid providing sick care. It's, to your point, it's probably not cost effective and a multitude of other things. It's not the right thing to do for patients either. But what you mentioned keeping track of some metrics in terms of evaluating how you provide primary care. What do you think are effective metrics for a healthcare organization to use to kind of be best able to navigate that space? Because that seems like a really hard thing to do, come up with quality metrics. So interested to hear what you have to say.
Yeah, great question. And I think we can look at, so what's happened over the years, we can look at this in a bunch of different ways. We've come up with our own quality metrics in the past. We want to see how we're doing with our diabetic patients, or we want to see how we're doing with our hypertensive patients, or whatever chronic disease. We certainly had pain as a scale at one point, and we were probably a little bit ill-informed on pain, and what we really should have been looking at is addiction earlier in my career, and now we've moved to really focusing on addiction as well, or pain and addiction. So we came up with these quality scores on our own. The trouble was there was no real benchmarking that was across the board. To your point, it's hard to do, right? So when we became when we became I guess it was first with the FQHC, there's actually this thing called Uniform Data System. And so it's all quality outcomes, which looks at the universe of care that we deliver here. So we deliver care to about 25,000 patients in southern Vermont and New Hampshire, and southern central kind of area. And that's about 100,000 visits per year. And so we have a pretty good benchmark or a denominator of all of the pieces that we have. So we can start to run those numbers. The uniform data system is actually a movement of what you're trying to think about and achieve here is all of the quality data from all of the FQHCs across America compared. And so I can take specific questions about, how many patients are you taking care of that are hypertensive, and or what are your out of control diabetic scores, or what are your cholesterol scores? How about maternal child? All of these pieces that are broken out, and you can Google these, and these are completely out there for all the FQHCs on HHS or HRSA's website. So if you look up uniform data or UDS scores, so if you look up UDS scores for North Star Health, I think we're in there as maybe Springfield Medical Care Systems because North Star Health is a DBA, but you'll be able to actually pull geographically from a map across America and compare. And so we'll get those scores annually, and we'll look at how we compare to other Vermont settings and New Hampshire settings or New England. And then we look at what we are nationally too. And if we're exceeding it, we usually get a call from HRSA, and HRSA will say, "Hey, how are you doing such a good job at this?" Which has happened before for us. And then you'll also get a call from HRSA saying, "Hey, why are you doing so poorly at this?" And we'll have to look at, "Hey, we aren't doing so good there. Why? Did we have turnover of somebody that was an expert? Has the process fallen apart? Let's do an analysis to see how we can improve things." So that's, in a way, to your question, in a way, it's dictated to us by HRSA, which I actually dig. And I'm not a huge socialist kind of experiment guy, but when you look at things like EHRs, right? So we're all on different EHRs across America. It's a huge pain in the butt. The VA's got it figured out. Why can't we just be on one system? And it's that whole free market getting in the way, and I get it, but it would be really nice to be able to just have one system so we can compare everything. Like, look at infection rates in the ORs. Do you want to go to a hospital that has constant infection rates with their knees, or do you want to get a knee replacement there? Not so much. So it's really being able to know that information ahead of time and publicizing it and making it transparent for patients. And I think there's a little bit of, you're going to choose where you're going to have the best outcome. I am working really hard to get all of our quality scores publicized in our waiting rooms. And so we're doing a lot of work. We've seen a huge amount of improvement in how we collect our data. And I think, Zachary, to your question too, and to your point, how you measure it is going to be key. And where you harvest that data from is even more important. So as clinicians, you're going to be having an EHR in front of you, right? You're probably going to have an AI applicant or an AI scribe or some sort of AI apparatus hooked to your belt or around your neck, like your stethoscope, or it's going to be on a shelf somewhere like an iPhone, right? This is happening already here. We have a company that we're working with AI that's transcribing everything. But the unique data has to be put in a specific place to be harvested when we run reports. If it's not there, you could have the best conversation about some sort of comorbidities with your patients. But if you didn't document that in the right spot, when I run a report, you're not getting any credit for it. It looks like you didn't even do it. And that's how the insurance company is going to view it. You didn't do it. And that is unfair. And that is a problem that exists today with the EHRs when they were sold to medical staff, mostly, of making your job easier. It doesn't make your job easier. It changes your job. I like the fact that you're coming out and that's all you've done. You've never done paper charts. And the folks that have always said, "Oh, I want to go back to paper charts," are slowly retiring from my system too. But what I think is done is, and it's going to be a challenge, or it has been a challenge, is that takes away that face-to-face time you have with your patients. Looking them in the eye, hearing them, listening to them is so important. I think AI is going to bring that back a bit, so you don't have to have a laptop in front of you all the time. And I'm really looking forward to that. So there's a lot of components from the quality piece that are dictated to us from the feds. I love that. And then we can publish it and then be side-by-side comparison to others. It's going to keep us doing the best job that we possibly can. Good question.
Any other questions from the interns?
Does anybody have a real hard one that they don't want to ask? Because that's the one I want, if you get a real hard one.
I have one. I don't know if you can
Yeah, do
see
it.
the card.
All right.
I was wondering if you could talk a little bit about the negotiation Springfield had with, like the management team had with like Dartmouth.
Hmm.
Guys were going through bankruptcy and trying to get kind of absorbed by the Dartmouth medical system, and kind of why Dartmouth refused, and then maybe if the merger had gone through, what some of the advantages and disadvantages of that would have been.
Okay, yeah, great question. So Marvin spilled the beans on some of the negotiations we've had, I see. So I would say the idea, if you're familiar with bankruptcy, and I was not, but I learned a lot about bankruptcy. What you're working with when you're in bankruptcy is that you can do like a bootstrap uh, recovery from bankruptcy, which means like you're pulling yourself up by your bootstraps, right? And then there's also something called a stalking horse. And that's going to be in this case, that would have been a Dartmouth Hitchcock that would then take on your company and bring it back to life. I think with that, if you didn't go through the total bankruptcy price of it, what would happen is whoever it was, if it was Dartmouth or UVM or anybody that was local, that was big tertiary, if they brought us back on, they'd also inherit a lot of that debt. And so the business side of it from a chapter 11 is to reorganize and to wash debt out of a system. And who does that hurt? That hurts financial banks and things, right? And vendors. And so it's a painful process. And I think with Dartmouth, when we started conversations with Dartmouth, there was a thought of potentially combining Springfield with other hospitals, and so you look at, if you're familiar with this area specifically, there's Valley Regional over in Claremont, New Hampshire, and then there's a Scutney Hospital in Windsor, Vermont, and both of those hospitals have recently been worked at joining together, and they're both critical access hospitals, 25-bed hospitals. Um, and I think that's a really cool thing to do. And I think you can share staff. I think you can share services. You share all your overhead. You only have one CEO, one COO, one CMO, right? And so you were able to control costs in a better way, and then that should translate to better employee salaries. That should transfer to better equipment that you're purchasing because you don't have to waste it on overhead. And so we probably would have been the third in that. And so this is actually a model that was looked at back in way before my time, back in the 80s. And some of the area that we have around here was populated by the Abenaki tribe. And so I know that the discussion, it was called the Abenaki Health System, was some of the code name, I guess it was, before my time when it was discussed. And it never made it forward. And there was no financial benefit for Dartmouth to take us on by any means at the time. And I think that the only reason that they would have done anything like that is for the betterment of care delivery and making sure that patients had a place to go locally within their community. At the same time, there was a lot of conversations with Dartmouth going on with the Granite Health System merger, and they were also talking about bringing Valley Regional on at the time. So I think part of it was probably bandwidth. I think Springfield Hospital walked away and Dartmouth walked away. And so it wasn't necessarily one party, it just didn't work out. And part of that was when you join up with a larger organization, similar to what we've done here, all of these primary care offices that we've inherited over the years were privately owned by physicians. And the reimbursement kept going down and the reimbursement kept going down, and they kept paying their staff more. And then they started paying themselves less until they came to the hospital and said, hey, own this private practice and I can't even pay my bills. I'm paying all my staff and the reimbursement's garbage. And the hospitals took them on. And there was no change in reimbursement. It's just the hospitals took on the loss. And so that's why you don't see a lot of private practices anymore. And so I think that's really what Dartmouth would have done. They would have just added to their loss with having a small hospital come on board. But at the same time, in order for a small hospital to come on board, you also have to act like a Dartmouth hospital because you will be one. So you're going to be asked to do different things. And sometimes little independent boards don't want to hear that. And what they want to do is they want to keep on doing what they're doing and just have somebody else write the checks. Well, it doesn't work that way. And so I think that's where a lot of the conversation ended up stalling down. And I was really concerned because that I think would have been a great solution. The Dartmouth folks are fantastic. I think we had a lot to offer here at Springfield Hospital for them as well. And so I think that could have been a sustainability piece. There's some conversation that I'm working on right now with Grace Cottage, which is a small critical access hospital, they don't have any ORs or anything, but they have an inpatient side of it. And then Springfield Hospital, as well as Brattleboro Memorial Hospital, which is a Medicare dependent hospital. And so how can we share staff? We're not part of Dartmouth, the three of us. And what can we do? I say three, but four, because I'm the FQHC weirdo in the group. But how could we work together to help each other? And we're actually in the process of moving our FQHC into the Brattleboro region, and taking over not private, but hospital-owned primary care from Brattleboro, which will save them a considerable amount of money from our reimbursement, and they will keep us whole. And so that's a nice way to do better for the community and really be able to spread our wings and have an economies of scale. Hopefully that answered your question.
I could keep going.
Keep going.
This
is your
Does
time.
anyone else have any other questions? No? Okay. I was wondering, so you're from Vermont, you grew up in Springfield, right?
I was born at Springfield Hospital, believe it or not.
Oh,
Actually,
that's
weirdly
a
enough,
full circle moment.
it totally is. And I'll give you a quick story. My first office at Springfield Hospital, after I left billing and reimbursement, I was moved to this one room up to the hospital, and my mom came to visit. So my mom and dad came, and my mom walks in, and she's like looking around. I'm like, "What are you doing?" She's like, "Well, this used to be the childbirth center." And I was like, "Oh yeah, I heard about that." And she goes, "I think this way." And I'm like, "Oh, no. I don't even want to know anymore." Apparently that my first office at the hospital was the room I was born in. So that's just totally wild.
Wow, that is crazy. That's really cool, actually. I wanted to ask what kind of the feeling of the Springfield community was during the time that you guys were going through bankruptcy, and kind of how they felt about the possible economic impact of if this hospital went under. And I did hear that you did have to close some units, particularly OB. So I was wondering if you could kind of just talk about how the community felt while all of this was happening.
Yeah, I think the community was pissed, for a lack of a better word. And they were really upset that they were in that position. They were upset that they were learning that they were going to lose their hospital. They had pitchforks and torches. They really wanted to find out who's responsible for this. And there really wasn't a single person responsible for it. There was poor decisions probably that led to it, but it was a long coming issue. It wasn't an immediate issue. And I think there was a lot of lack of understanding by the general population. Like, how does a hospital go bankrupt? They're doctors and stuff. They get paid a lot of money. I mean, how would they go bankrupt? And it's like, well, you don't know how it works. And so nobody knows how it works. So when you sit somebody down, and we had some really, I would say, grassroots community folks that came up that wanted to help us solve the problem. And they were really good business people too. And you start explaining the healthcare business and how it works, and they just turn green and their eyes would go cross, and they'd be like, "I don't know how you do this." It's like, welcome to healthcare delivery. It is a very unique business to be in. And I have a lot of business experience. And so it's like, some of the stuff doesn't make sense. And that's part of the problem with healthcare. So I think, yeah, I walked into Shaw's. I'll pick on Shaw's again. So I walked into Shaw's. I was getting some groceries, right? And I hear from across the entire supermarket, "Are we going to have a hospital tomorrow, Josh?" This guy just yelling at me across from way on the other side. And I'm just like, you can't go anywhere. It's a small community, right? Everybody knows. They know my role. They know I was put as an interim CEO during that time. We had another group come in there were Ovation to come in to help. They had experience running hospitals. And they came in and they became the interim CEO of the hospital. I became the interim CEO of the FQHC, and we started to pull those systems apart. Oddly enough, they shouldn't have been. Probably in hindsight, we never had to pull them apart, because the only reason we pulled them apart was to get Dartmouth at the table, and an FQHC can't be above or can't be below a hospital. And so we would have had to put the FQHC above Dartmouth, and fat chance. There's no way that would ever happen. So that's why why we broke them apart. So yeah, I think the community, they had some choice words. And I think as it went through further, like don't read social media when you're going through bankruptcy, right? It was just like the hate. But as we got to the other side of it, I think people looked at the folks that stayed as more heroic of being able to make it through the fire and getting to the other side. And oddly enough, I've been asked a lot about that experience and what I've learned through that process, with people either looking at doing that process now or people that just want to know how to survive in a really difficult environment. Yeah, that's a good one, Betty. I'm happy to speak to what Dr. Hummery said about Act 167 too, if anybody would be curious. Oh, Natalie or Natalia.
No
Sorry.
worries. No worries. Um, so I'm curious, so North Star Split and Springfield Hospital continue to operate as like a separate entity. I'm
Yes.
curious how that's looked for both of you, and like financially, how, and then as far as like the services that you're both able to offer, how that has maybe changed. Um, and then also I was just kind of curious because you're talking to other people who are thinking about doing the same thing or going through similar processes. Is this like something that, and it sounds like maybe other organizations in Vermont are looking at doing a similar thing that you did maybe preemptively. So I'm curious to hear about that as something that people might do before they're already in bankruptcy.
Yeah. Yes, I think the first thing that we can talk about, I didn't really touch on it before, but cutting the OB services at Springfield Hospital was a really emotional meeting. I've got two older kids that were born at Springfield Hospital. I was born at Springfield Hospital. My parents were born so it was kind of like this, oh my gosh, this is the end, right? And that made it really difficult. I remember that board meeting. It was, you could hear a pin drop as we all voted to close the childbirth unit and then find a place for those moms. There's soon to be moms that were circling the tower, it was like air traffic control. All of a sudden you took the runway out, and making sure that they have a place that they can go to and feel supported was very important. And so we were able to do that. But I had to sit in the childbirth unit and I had to tell all of the nurses that they weren't going to have a job. And that was not a highlight. And those are the worst things you can ever do as a leader. It's saying that we have to do something that's going to impact them, their families, their lives. I knew they were going to be fine because there's such a demand for nurses, but it's just a really tough thing to have to go through. And so I think there's other hospitals right now, absolutely, in Vermont, looking at services saying, do we need to do this? And the hard part is hospitals have always done what the community asks for. So if the community says, we really need this, the hospitals will try to find a way to do it. We need somebody to be able to give Coumadin at the hospital. We need oncology services at the hospital. Well, those are hard to find. And so we contract with other hospitals, like larger hospitals, to try to have those services. But now those larger hospitals are having a hard time finding those people. So now you're not seeing those even be open at larger hospitals as much. And I think that the community, again, doesn't understand that scarcity of resources. And so they're saying, well, they took this away. They're taking another thing away. I had to close a rural healthcare site down in Bells Falls, Vermont. And as clinicians, sometimes you have to cut off the arm to save the patient. And that was an arm of ours. Childbirth Center was an arm of ours, if you will, right? And so we had to amputate both of those sites. And that it's hard to recover from that, especially when you have patients that are used to walking to a site and now that site's gone. And so now they have to have a ride. Well, if they don't have a car, they have to rely on the transportation service, which is sparse. And so that makes it even more difficult. So those were tough pieces to try to really get through. And tough for my career piece. But Natalia, I drifted a little bit, so I want to get back to your core question. So remind me exactly to zero in.
Yeah, I was curious not only about how North Star fared on the other end of things, but also how Springfield Hospital
Yep.
fared after the restructuring.
So after that, thank you for zeroing me back in. So the other piece with Springfield Hospital and the FQHC or North Star, when we split, it was a little bit like a divorce. And so if you've gone through divorce, have friends or family have gone through divorce, you've seen it, it's kind of like that, where you have Springfield Hospital's calling me right now, actually. So it's a little bit like you're fighting over the kids, and who has custody of who somewhat. because we are so close together and because we compete with each other a little bit for staffing, right? If we're recruiting for a nurse, they might also be looking at a job at Springfield Hospital. From an outpatient setting, not so much for clinicians, because we do all of the primary care for this area. So if Springfield Hospital were to start doing primary care, it would be a really poor decision on Springfield Hospital's part, because they get paid so poorly for primary care, because it wouldn't be an FQHC or a rural health center. So certainly that was a struggle to get through. You know, the CEO of Springfield Hospital and I work very closely together. We're on the phone or in a meeting every Friday, kind of saying, how's it going? What are you up to? What are you struggling with? And sometimes I'll have different ideas that the Springfield Hospital CEO may not necessarily agree with. You know, I could send all of my labs. This is a good example. We were talking about laboratory services, and I could send all my labs to Quest, or I could send all my labs to LabCorp, a national lab service, and I would save my patients money because they're a national service. It would be cheaper to process those labs. Or I could contract with Springfield Hospital to do the lab phlebotomy on my sites. And so that would hurt Springfield Hospital if I didn't. And they are relying on some of that revenue right now. So it's really getting through those conversations to be like, well, here's why it makes sense for me to do this. And they could say, well, it really would hurt us if you did this. And I don't know if we'd be able to support other services because we're relying on that income. And it's just, these are conversations that you're just having, and you're trying to make the best decision for your organization or the population that you serve. Because it's, if we're not here, then they've got nothing. And that's one of the things that we've had to really navigate. We also had shared services. So we would have a part of HR 50-50, you know, we would share an FTE between the two, or full-time equivalent, or just a person. We would share a person, you know, back and forth. And what I noticed is we were second fiddle every time. From an FQHC or primary care, if it's not necessarily the first group that you call, because it's looked at as it's a necessary evil potentially by some hospitals. Yeah, we have to have primary care. I mean, we're going to wine and dine the surgical department and orthopedics and everything, but for primary care, you know, and it's a real problem. And so we have to advocate for ourselves quite a bit. And some of the decisions that we made for ourselves right out of bankruptcy, so during COVID, right after bankruptcy, we ended up transitioning to a different EHR, and we moved out of Allscripts Professional. We moved into Athena One, which was a huge bonus for us. Our providers are much better off. Our patients are much better off using Athena One. It's certainly not, I've never met anybody that says, I love this EHR. And I had a physician, super smart physician, say to me, well, that's because all the good programmers are working for Microsoft and Sony, making Xbox games and PlayStation games. They're not working for EHR companies. And I was like, yeah, that could be very true. She's very smart. And so, you know, that we chose an EHR that best was suited for us in primary care. And the hospital was stuck with some Allscripts on their specialty side of it. And there was initially dialogue like, why are you doing this, Josh, to us? And by the hospital. And it was, I'm not doing this to you. I'm doing this to better serve our community. And I'm doing this to reduce any burden that my primary care staff has on their table, which is a lot, because they're charting all night right now because Allscripts is so difficult to manage. And let's get to Athena, where it's more intuitive. And it helped. And plus, I was able to save a lot of money on the billing side of it. And so it was a win-win for us. But we've come a long, long way since then. And we really know we're trying to be as sharp as we can to support our own infrastructure while we continue to have a relationship with Springfield Hospital, just as we would with Valley Regional or Ascutney or any of the other hospitals around us that we work closely with. Did that answer all your questions? Good.
So we have you on the schedule to go up till noon.
Yep.
So we have about 3 minutes left now. I think of the two questions that Dr. Keller has in the chat, we might be interested about hearing about, since it just happened, what the impacts of the big, beautiful bill will be on your hospital system. And Dr. Keller specifically asking if a lot of hospitals or FQHCs are jumping to apply for some of the funding that has to be submitted and approved before the end of this year.
I think the answer is going to be yes. I think the unfortunate side is we don't really understand the changes yet completely. We have, I'm going over, I have a board meeting Tuesday night, and I have a presentation that I got from our primary care association, Bi-State Primary Care, that really outlines everything. Like, but it's always worst case scenario, right? The worst case scenario, this, that, and this. And so I haven't had a meeting where we talk about positive things in a very long time, but it's like, here's the bear at the end of the cave, and we're getting closer to it. And, I think we're still dissecting those pieces. One of the biggest fears that we have right now is Medicaid and the collapse of Medicaid and making it very difficult for patients to be on Medicaid. Do I think there's people abusing Medicaid that probably don't need to be on it? Absolutely. Do we need to do something about it? Absolutely. Do we need to cut down Medicaid so that it's detrimental for everybody? No. And so, the thing is with us as an FQHC and like a Springfield hospital, as a critical access hospital, in any hospital in emergency room settings, emergency rooms have to take care of people when they show up, right? It's EMTALA, it's the law. And so you can't just turn somebody away. And if they don't have Medicare coverage, or I'm sorry, Medicaid coverage, are we still going to see them? Yeah, we are. If they come and they present to North Star Health at walk-in or established primary care and they can't pay their bills, are we still going to see them? Yeah, we are. We're just not going to get reimbursed for any of it. And so that's a huge fear. How do you do that? How do you do, and I say this in a lot of the meetings that I have, how do I do more for less? I've been doing that for my 20 years that I've been in healthcare. It's always been about cutting cost, it seems. And I'm good with doing more with less, but I can't do more with nothing. In fact, I can't do anything with nothing. And that's how close we are. And, I don't know if the overarching goal is eventually to reduce salaries or markets in healthcare, but the state of Vermont has done a job trying to do that, Green Mountain Care Board specifically. And what you're seeing is not every state has a Green Mountain Care Board. There's not a White Mountain Care Board over in New Hampshire. And so you see the market industry trends continuing over there. Within Vermont, it's harder. So people will just say, well, I'll just go work in another state. And all of a sudden you don't have a healthcare system in Vermont. So it's a very difficult and delicate system on the state level. And with the federal pressures that we're starting to see now and the uncertainty, I think it's even more scary. We have had patients come to us thinking, as soon as Trump went into office, they were thinking they didn't have benefits anymore. And so we had people coming in saying, I don't think I have Medicaid anymore, and I don't know if I should be seen, and I'm seeing patients every day that are disappointed that they had to come in to be seen because there's an ailment that they have going on, because they're trying to save every single dollar that they can, because their dollars are not going far anymore. And when they're going to the grocery store, I'll pick on Shaw's again, you're not able to fill your cart or basket or even your hands. And so it's really a tough spot if somebody has to pay a copay or a deductible. Some of those laws have changed where that will not count against you on your credit. And I think credit agencies have never really looked at healthcare debt as we get it. You couldn't pay your healthcare debt. It's expensive. It's not, we understand, but your visa, you paid that. And so it's really kind of a difficult position that we're in. So I think, yeah, FQHCs and hospitals on the federal side, I think we're all bracing for it. I think we're going to try to, there's some rural funding that's available within the bill. We'll definitely be going after that. I think one of the hardships is it would have been nice to just take care of patients, and that's what we should be doing, but we have to chase the dollar all the time. And so it's harder to focus on what we're here to do when you're taking all of the bandwidth from your team to focus on chasing survival mechanisms, which is what a lot of us are tied up with doing. So I know we're kind of at the end, right? So I'm going to put my email in the chat.
Thank you so much for talking to us.
My pleasure. And if you want to stay in Vermont and you want to stay in primary care, I want you to call me. Or New Hampshire, right? Because I'm always looking for some bright and the best. That's my cell phone. So you can call me and anytime you want. If you text me, go ahead and text me. Just say who you are. Otherwise, I'll think you're one of those AI spam bots. I'd love to help you along your journey. Thank you for what you're doing, because it's a difficult journey that you're on. There's no doubt. And there's going to be days that you're like, why did I do this? And there's going to be like days that you say, thank God I did this. And so I just really appreciate all of you so much for everything that you've been doing.
Thank you so, so much for taking time out of your day to talk to us.
Oh, my pleasure. I'm glad I made it in under that because you guys are almost done, right? So I just barely
Yeah,
made it
yeah,
in.
you're our last guest speaker, so we ended on a bang for sure.
Nice. That's great. Well, thank you all so much. And I hope you have a great weekend and the rest of the school. Take
Thank
care.
you. Bye-bye.
Thank you.
Thank you.